Okay, good afternoon, everybody. Welcome back. Okay, guys, first of all, hope everybody enjoyed lunch. And let's give a round of applause to the Lionhead faculty here for doing such a great job. Thank you. Thank you, staff, for keeping us fed and happy. Thank you. And so, moving on along to this afternoon's topic, I get the privilege of introducing someone I get to call friend and who I've known for about 3 decades now. And we're very, very privileged to have him here. He's had multiple roles at the hospital, at the region, and he didn't want me to highlight any of them. It will take me 20 minutes to go through all of those. But right now, he's going to be speaking to us as our regional primary care, I'm not primary care, sorry, endoscopy lead for our regional cancer program. He's going to be talking to us about colorectal cancer screening. And so without any further ado, Dr. Andrew Bellini.
Thank you very much, Praveen, for that kind introduction. As I stand before you on this lovely golf course, well into the back nine of my career, it's hard not to be a little bit nostalgic. And I think you kind of saw that nostalgic sentiment in some of the other presenters that were with the Regional Cancer Program for a long time. I've been with the program for 10 years now. And, it's been a privilege and a pleasure to work with such fine and dedicated people at the Regional Cancer Program and Cancer Care Ontario, and just want to say that before I start. So I've got some good news and some bad news. The good news is I'm going to give you some time back because my presentation's a little shorter. The bad news is the second half of my talk. I found out yesterday afternoon that it's a little bit too soon to present. So we're not allowed to present you some of the data that I was hoping to share with you. But I am going to talk to you a little bit about the rising incidence of colorectal cancer in young people, which I think is a really relevant and really interesting topic. You'll see the agenda items are a little bit abbreviated. There are a few others, but they have been redacted. A little bit of fun trivia to start. Colorectal cancer, I should have been more organized to have one of those vote on your phone things, but ranked from highest to lowest, number of number of cancer-related deaths diagnosed in Ontario, 2024, in males and females combined. So that's a little bit of a trick, right? Because you have breast and prostate. So I'll let you guys formulate your opinions in your brain. So these are the numbers. So colon is number 2 in colon cancer-related deaths. So I'm not sure if that's something that everyone would have recognized. It's interesting that pancreas is number 3, and I was just talking with some colleagues about how awful pancreatic cancer is, and we've done such great progress in medicine and oncology, but even though it's maybe not as common, it's just more fatal. And I think, at least me, when I looked at that question, I always thought breast cancer would be higher because it's such a common cancer, but I think we've just gotten much better at treating it. And then I think this is an easier question in terms of if you're diagnosed with colon cancer, if you find it early, what are the outcomes? And I think we've got a pretty well-educated group of practitioners and support teams here today. And I think we all know that. I'm just going to go back. So it's over 90% survivals if you find it early. So that's one of the reasons why we advocate so much for colorectal cancer screening, because if we find it early, obviously we can make a big difference. And then the other question is what percentage of people with colon cancer have no family history of the disease? And again, this is a question that comes up a lot, but it's about 70%. So only 30% of people with colon cancer have a family history. So it's important to screen for colon cancer in everyone, males, females. It does not discriminate. So a few more fun facts. Colon cancer accounts for about 10% of all cancer deaths. The lifelong probability of colon cancer is 1 in 22. I remember when I was studying for my GI fellowships just a couple of years ago. It was a different number. I remember it was about 6% was what was in Schlesinger and Fortran in the 90s. When caught early, 9 out of 10 can be cured. So it's still a very, very common cancer. What's interesting is that the natural history of development of colon cancer has been changing underneath our nose. The other things I'd like to mention is that there seems to be a disproportionate burden of colon cancer, along with some of the themes we've heard earlier in the talks today, that there are certain underserved socio-demographic groups where there's a higher than expected burden of disease. We don't have really complete data, but we do have some data in the Indigenous population. And in Ontario, in First Nations persons in Ontario, they have a higher incidence and mortality of colon cancer and a lower chance of surviving. So, as we work to improve with our cancer plan, like was presented earlier today, this is certainly something that we're trying to address. There's some special problems in reaching some populations, including the Indigenous and First Nations populations. And again, some of the access issues to screening are going to be addressed. And at a future talk, I'll be able to tell you maybe some enhancements that might be coming down the road. And this is a graphic form of some data in colorectal cancer incidence in First Nations populations in Ontario, that the curve seems to be shifted left in terms of when the diagnosis occurs and when the cancer develops. So they seem to occur in different or at an earlier age. I've seen some similar data in African Americans in the United States, a very similar kind of shift to the left graph. So I think everyone here is really familiar with the colon cancer check program. It's been around for a long time, started with the fecal occult blood test, and then we launched FIT in 2019. It's a very robust program. We talked about screening targets. I think Tiffany was talking about 60% targets, and our target's been raised to 65%. Aspirational targets, 80%. Kaiser Permanente in Northern California has been able to get there, so they've shown that you can get there, but it certainly takes a lot of work. And like we spoke about earlier, our region does struggle with this quality metric. There's a number of barriers in our region to try to get everyone screened. So our program started in 2008. I think the letters are a real driver. I think those are really valuable. I know what my patients often that's how they get into the screening program, and statistically it really drives screening rates. And the program divides people into two categories. It's pretty simple. It's low risk and high risk. Low risk or average risk screening is with the FIT program. That's the recommendation. And then higher risk is with colonoscopy. And colon cancer kind of fits all the big items that you want in a screening program. It's a common condition. It's burdensome. There's a acceptable test to screen for it that can make a difference, and a test that's acceptable to people. And there's an infrastructure in place to monitor a program, and we've got a fantastic program. So it's like check, check, check. Colon cancer is a great target for a screening program. And the goals of the program, and I think that these themes have been mentioned before, is to maximize benefit and reduce harms of overscreening. I'll wait for the pictures. Now, the interesting thing is that there's a rising incidence of colorectal cancer in younger people. And Cancer Care Ontario has been recognizing that, and they have been looking at the evidence and modeling and deciding what to do with this. And I'll show you some of the early evidence here. This is birth cohort data. So the y-axis is your relative risk of developing colon cancer in your lifetime. And this is based on the year you were born. And it's in men and in women. And the graphs are pretty well the same. So I would just choose the left or right, whichever is your favorite. So if you're born in the 1920s or 1940s, your risk of colon cancer was the same. But I was born in the 60s. You can see here. Does this have a pointer at the bottom? Thank you, Gal. You can see right here there's a bit of an inflection. So you can see if you're born in the 60s, it starts to go up. If you're born in the 80s, it's up. And if you're born after 1980, you're almost 3 times more likely to develop colon cancer in your life than if you're old like me. So that's troubling. Having said that, if you look at people that are in an older age bracket, if anything, the trend is that the colon cancer rates are going down. But you can see in young people, it seems to be going up. And the caveat is, even though there's a high risk or a higher risk in young people, it's still much more common in older people. So I don't want you to go home thinking that all this cancers are coming in young people and old people aren't getting cancer anymore. Older people have a much higher risk, but it is troubling that younger people are developing cancer at a higher rate than they have been historically, that rate seems to be trending up. And unfortunately, when those cases are found, they tend to be found at a later stage, and there's a whole number of reasons. But I think it's pretty easy to see a 20-year-old's abdominal symptoms maybe not taken perhaps as seriously as a 70-year-old's abdominal symptoms in terms of what we perceive in terms of our biases. Did anyone do those bias tests as part of their accreditation? Anyway, it's an interesting topic, how cognitive biases affect us. This is another nice graph that looks at colon cancer incidence in younger adults. And the nice thing about this is it's Ontario data. So these are our patients. So in yellow, it's 50 to 54. In blue, it's 45 to 49. And you can see in both those age groups, like in that other modeling, you see if you look through the years, it's getting more common. So the slopes of those lines are both kind of heading up. So again, a little bit troubling, still lower in people 45 to 49 versus over 50, but going in the wrong direction. I kind of apologize and kind of don't apologize for this graph. This is from JAMA, just from January 22nd to 2026. These are the leading cancer deaths in people younger than 50. And you can see you've got a number of cancers here. I want you to focus on the reddy orange line here that's going up. That's colon cancer, colon and rectal cancer. All the other cancers, for the most part, seem pretty stable or reducing in incidence, and colon cancer is going the wrong way. This is in people under 50. So it doesn't seem like there's a birth cohort effect that they're getting all sorts of different cancers. It seems like they're getting colon cancer, which leads to the big question is why. And I wish I had that answer, but I'm going to show you a few things that we can speculate about. So, it's funny, I remember in the 80s in med school seeing graphs like this when we were talking about the causes of peptic ulcer disease, and we had mucosal protective factors and mucosal aggressive factors, NSAIDs, aspirin. We knew nothing about Helicobacter pylori being the major cause, but when you don't know the answer, you kind of try to break it down into potentials, right? So early life exposures, we do know that metabolic syndrome, steatohepatitis, fatty liver disease, that whole obesity metabolic syndrome is associated with increased risk of colon cancers as well. There was just an article published, a whole range of cancers. We all suspect that a bad diet and lifestyle, and we've got burgers and alcohol here, might be associated with higher risks of colon cancers. But the exact magnitude of these risks, it's still not completely worked out. This is a summary from a review article on the risk factors for early onset colorectal cancer and adenomas, and you've got the hazard ratios. It's a little bit of a busy slide, but some of the big risk factors were obesity, diabetes, metabolic syndrome, fatty liver disease. There was one publication from Sweden that if you were born by cesarean section and you're a female, that you might, so I don't think anyone knows about that, so just ignore that section. The other is alcohol, seems to be a risk factor. And I think I've got another slide to show you on alcohol. Sedentary behavior, diet quality. There's this thing called the sulfur microbial diet. It's really just like a bad diet, like drinking Coca-Cola and eating burgers. And sounds like a fun March break, but it's probably not a path to a healthy lifestyle. Now, I can't show you a slide of risk factors without anything that's been associated the other way. So, NSAID. Oh, sorry about that. NSAIDs we know seem to be like in polyposis syndromes, probably some protective effect. Aspirin's pretty controversial. Vitamin D's controversial. This I wanted to include because I think it's important to keep everything in perspective when we're advising our patients, right? So I think general principle, eating healthier food, exercising, but when you get into it and you look and you break down the data from different countries, and it's not quite as clear as you would think. If you look at Italy here, and they define alcohol as more than 3 alcoholic beverages a day. And we all know that the Canadian guideline is 2 alcoholic beverages per week, right? So we're not talking like, we're talking like outliers, perhaps. But you had a lower risk of colorectal cancer if you're drinking wine. And then if you're Italian, you eat vegetables. Look at that. You should eat less vegetables and drink more wine. So you did not hear me say that. Do not quote me on that. But what I'm saying is we take it with a grain of salt. In general, yeah, higher alcohol intakes are associated with worse health outcomes, healthier diets. But I caution you that this is all self-reported data, and it varies by country and region. So the whole story is not known. We do have some data, though. There was a population-based study out of Germany that investigated the relationship between healthy lifestyles. And again, these are things we can all get on board with. Not smoking, drinking a reasonable or low amount of alcohol, eating healthy, physical activity, healthy BMI. No one's, I don't think, going to argue with that. And the risk of colorectal cancer. And each lifestyle factor that you modified, so if you improve these, it was associated with a reduced risk of colon cancer. And if you did even better and reduced more than one lifestyle, there was an additive effect. So I think the primary care takeaway is that we should encourage a healthy lifestyle in our patients, probably not only for colon cancer risk, but for cardiovascular and general health benefits as well. I think there's just a repeat of the slide that I showed with all the potential factors that are leading to this increased risk. Again, I think one of the other take-home messages I'd like to leave you with is that if people do have abdominal symptoms and they're under 50, just to be aware and to let it enter your differential diagnosis that it should be taken seriously, because we are seeing cancers in young people, and they tend to be found late. I think this is I apologize. I redid my slides last night after finding out that my talk had changed. So I think I kind of screwed up having the slides a little bit out of order. I apologize. This is, I'm not sure if this is one of the ones that I was supposed to delete, but a lot of colon cancers are preventable. I'll just skip ahead. Certainly with this data, we're aware of it. I can't comment as to what changes may be coming, but stay tuned. We plan to be doing more talks, and I've got a very engaged audience here, so there's going to be newsletters, webinars, family practice grand rounds that have already been booked. So you will be hearing from me again with all that content that I can't share with you today. If you don't know about our website, eventually as soon as we're allowed to post the material, things for CME as well as resources, mhcwrcp.ca. So it's a really nice resource. We'd like to get all of the, I had heard the comments about making it easy, so we're going to try to get the referral forms and the fax numbers for all of the FIT screening programs at our major partners through the region on here, as well as other resources. So if you haven't seen the website, it's actually a pretty good website, and it's not just for colorectal cancer. Please check it out. And that is, unfortunately, it for today. Thank you very much.
Any questions for Dr. Bellini? Can we get a mic back there, please? Of course.
I was saying I should just run out the door so people don't ask me any questions I can't answer. Yes.
We're here to embarrass you.
Oh.
So if a patient goes for their screening, colorectal screening, and has a screening colonoscopy, and they find a polyp, and they're advised to return in either 3 years or 5 years for follow-up, is that person, would you advise that person that they don't need to do their FIT test anymore?
So that's a complicated question, and the answer, as it is for almost all of those questions, is it depends. So it depends on their risk level, so on their family history, on the nature of the polyps they've had on that occasion and in the past. It puts primary care docs in a tough spot, right? So you've got a specialist that says, come back in 3 years or come back in 5 years, right? There are some I'll give you a couple of useful situations. So if you've got someone with no risk factors, no family history of colon cancer, they don't have colitis, and they had a hyperplastic rectal polyp removed, right? A hyperplastic rectal polyp doesn't count. That's a normal thing. So that's easy. So that's a normal. They should be returned to FIT. There's another concept of low-risk adenoma versus high-risk adenoma or sessile-serrated polyp. So again, we like to divide low-risk, high-risk. Low-risk adenoma is in that low-risk area. So the guideline is to return to FIT after 5 years. That's 1 or 2 tubular adenomas without any villus histology, without any higher grades of dysplasia, and without any family history, they can be returned to FIT. If they've had advanced adenomas, more than 3 simple adenomas or over a centimeter, then it's usually 3 to 5 years for a recheck. So it's a bit of a longer answer than yeah. We should probably put that on. I think I see Jennifer and Emily in the back. We should probably put that, if it's not already on our website, we should put Cancer Care Ontario's surveillance guidelines there, because that does get asked a lot, and I think it'd be a nice resource for primary care too. Silence. Oh, Gull. Yeah, so it wasn't immigration; it was by birth cohort.
Okay. So
Yeah. So if you divide people up by the year they were born. So I was born in the '60s. You were born a lot later.
80s. Yeah.
Don't want to put anyone on the spot. So your risk of developing colorectal cancer in your lifetime versus, or your generation's risk versus my generation's, like 2.5 times
But I thought
higher.
I saw something about like birth country as well. I don't know, maybe I reread slide 19 of your.
Let me. Do I have
Yeah,
drive
can
control or no?
you the red button will
Yeah,
push you back?
but I'm
It's
not sure if they
going?
kicked me out. There are some differences country to country, but they're not gigantic. And to be honest, North America tends to have a little bit of a higher risk than a lot of the countries that we see immigration to from our region. Thank you. 19? Yeah, so this is
The cohort, yeah, it's not, okay, I misread that. There was Dr. Aisha Lofters presented at Primary Care Oncology Day a couple of years ago, and she also indicated that the incidence of cancer in those who had come to Canada as opposed to their country of origin also increased. And we don't know if it's lifestyle factors or stress or.
Yeah, I've seen some immigration studies, gastric cancer risk in Japan, and it's interesting how often the risk tends to go to the new country that you go to, and probably dietary factors, lifestyle factors are part of that. All right.
Okay, Andrew, I have one more question
Sure.
that often comes to me. First of all, thank you for a great presentation. So one of the questions that often comes, I'm just going to refer my patients for a colonoscopy. It picks up polyps and it's better, and why even bother with a FIT? Could you give it like a 2 or 3 minute sort of advantage
Overview.
Overview, please.
Yeah. So it's a question we get a lot, and you're going to get different opinions. I'll preface it by saying you're going to get different opinions from different people you talk to. We did a debate at one of our primary cancer. Did I debate you? Oh no! It was a former lead. Yeah. So the best way to answer that is to say that it depends on what lens you're looking at. So if you look at it from a population-based screening lens, if you look at it from the Ministry of Health's perspective, right, and you say, well, I have a budget, right, and I've got $100 million to spend, and I want to do the most good, I want to reach the most people, and I want to be as equitable as possible to provide the screening service for my province, then hands down, FIT testing is way better, right? If you look at it from a personal point of view and say, what's best for me, then it's not quite as clear. So I think that's the best way. There have been some studies. I didn't include those slides today, but there have been some studies comparing colonoscopy and FIT testing. And if it's of interest, I can present those later. But again, it all, you can look. It depends on how you look at the data. But FIT does compare very favorably to colonoscopy when you look on an intent to screen basis, right? The intent to screen, not on people who actually do it. Yeah. There's another hand I saw, a couple.
Thank you very much for the good information. But from primary care perspective, we do fit test determine whether patient needs to be sent for colonoscopy.
Right.
When we've already determined that colonoscopy is needed in 3 years, what additional benefit we are getting to order that fit test? Because I'm assuming that there was a polyp that was removed. There might be some blood there, and now how that test changed my management when it is already determined?
Yeah, it's a good question. The way I would answer it is that once someone has, let's say, an advanced adenoma, they had a 1 centimeter tubular adenoma removed, the doctor says come back in 3 years, they've changed risk category. They're no longer in average risk, they're in that high risk. So they should not have a fit, they should go directly to colonoscopy at that 3-year interval. Having said that, if they had and again, I don't want to put the pressure on primary care, but if they had a 3 millimeter hyperplastic polyp in their rectum and were given bad advice to come back in 3 years, you could use your judgment, right, if you feel comfortable with it. But it is hard, and we're trying to do education among endoscopists to have their recommendations match guidelines. So that's something that we're working on, making it more clear communication.
Hi, can you comment on the miss rate on colonoscopies? I've had a couple of patients who were really tragic cases. They had a colonoscopy done within a year or two, and they're suddenly discovered with widespread cancer. And then when you ask the endoscopist or the facility, they just say, well, there's a miss rate. I guess a comment on miss rates, and also on, do you keep statistics on which hospitals or which endoscopists are missing more?
Do we keep statistics?
And then, not to publish them, but then at least to privately approach this, a facility or a hospital, say, wow, your miss rate is much higher than everybody else.
We do keep statistics. We keep,
because then those facilities could do like a quality improvement to get
there. Awesome question. So we've been keeping statistics for a long time. The whole issue of post-colonoscopy colorectal cancer, that's what you're referring to, is a 1-hour lecture in itself. And I promised I'd give everyone some time back. But it's really interesting, and it is a quality measure. It's reported on an institutional level. It's reported provincially. It's reported individually, right? If you have more cases, you'll probably get a call from me as an endoscopist and to review the cases and discuss. I just completed a few of those calls the other night because we're in our cycle of doing our quality improvement. They're all really interesting, tragic cases, and there are some factors. Overall, it's about they say the sensitivity of colonoscopy about 95%. There is a miss rate. But there's always a story. Like when you really delve in it, it's not like the doctor went there and there was a big tumor and he just didn't see it. The prep was poor. He told them to come back. They didn't come back. They come back and there's a tumor there. I'm sure it's similar like with some of the cervical. Some of these things are hard to see, right? So in general, endoscopists with a higher adenoma detection rate tend to have lower risks of post-colonoscopy colon cancer. So one of the things that we're trying to do is to try to educate, try to get the ADRs or adenoma detection rates up. But it's a systemic issue, but it's maybe not as simple as it sounds. If it's of interest as a topic, I'm not sure if that's of interest. It's kind of interest to endoscopists, but let us know in terms of feedback. If you'd like to hear more about, like I said, if you guys have rounds or whatever, I'd be happy to give a whole talk on that. All right, I'll shut up. Thank you.